So I just want to highlight another SWOG trial that is looking at upfront patients who've been diagnosed with BRCA or HRR mutation disease to give them platinum-based therapy and then go to the local treatment, usually surgery, because these are non-metastatic patients. So that is a study that is ongoing and hopefully will give us input as to whether we can improve outcomes in this patient population that has a worse prognosis.
Honestly, the most common counseling is for family members.
Yeah.
When it's wet to screen, which is sort of
Yeah.
a bit stating the obvious, but that's the conversations that we have at the time.
Yeah.
All right. Well, let's move on to the details of your treatment. So when you see a patient with metastatic disease, and I'd like each of the oncologists to chime in. I mean, obviously, urology and radiation oncology also feel free to give input in this kind of strong feelings and not using these medications. But maybe start with you, Phoebe.
Sure.
How does that discussion go for a metastatic patient?
Yeah.
De novo or even relapsed, and you can make that distinction. But in terms of treatment options,
I think in my clinic, I usually think first in my head like low volume, high volume. That's my distinguishing feature, of whether to bring up triple therapy as an option, and then let's just presume they have.
Want to define?
Oh, yes, thank you. Yeah.
Oh.
So that's defined from the CHARTED trial, the old CHARTED trial. So high volume disease is any visceral metastases, so like lung or liver, soft tissue disease, that's not a lymph node. And then more than 4 or more bone mets with at least, it's like such a long definition, with at least one of them being outside the spine and the pelvis, yeah. So that's considered high volume disease. So let's just presume they have low volume disease. Then we're talking about androgen deprivation therapy, as well testosterone lowering treatment, as well as adding a oral agent, an androgen receptor pathway inhibitor. And choosing between them, I think we kind of see them. They've never been compared head to head. Again, the VA has a trial that's doing that, abiraterone versus enzalutamide.
Yeah.
But I think I'll let Frank and Phil speak too, but I think we kind of see them as essentially equivalent in terms of their efficacy of treating the prostate cancer. So then we're really choosing based on comorbidities, some logistics related to the drugs. At the VA, I don't have to worry about this, but my colleagues down the street and at Karmanos have to worry about insurance issues, about cost and access to the drug. So we kind of go through that thought process with the patient, actually. And sometimes there's a very clear, obvious choice. For example, someone with significant heart failure or in and out of the hospital, atrial fibrillation, we'd sway away from abiraterone. Enzalutamide has lots of drug-drug interactions. So sometimes there's a clear choice, but other times there's not. And we kind of talk through the pros and cons of the different, I don't know about pros, but cons of the different options, the side effects, and then make a decision together with the patient.
Yeah, I agree totally with what Phoebe said, in that it's really a shared decision with the patient and based on their comorbid conditions. So obviously if you have heart disease, as Phoebe said, then abiraterone is not the best choice. If they have a complicated drug-drug interaction scheme, then often darolutamide is a good choice because it has less interactions. If you have neurologic or fatigue coming in, then enzalutamide may be less of a consideration. So it's really based on matching the patient to the drug characteristics to the best of our ability.
Yeah, and thankfully it keeps getting a little more complicated. It used to be 3 drugs, and now we have 4. So it used to be abiraterone, enzalutamide, apalutamide, and now we have darolutamide. So I still tend to use a little more of the first 3. The darolutamide, most recently came out. We don't have survival data, but certainly it's great for drug interactions and is well tolerated.
Yeah, I must say that is a very common thing. Like I have so many, at least half my patients seem to be on apixaban or some kind of blood thinner, which then, stops me right in my tracks when I try to do any of the other, enzalutamide type of medication. And darolutamide does not have that interaction, so it's been helpful. The other thing is, I just find that big distinction between the CYP17 inhibitor like abiraterone versus the androgen receptor pathway. I just find a big distinction between how cumbersome it is to monitor for abiraterone and all the electrolytes and, how often I have to keep tabs on the patient. So that sort of also sways me more towards the androgen receptor. But you're right, access is a big issue. And getting the medication to the patient, sometimes abiraterone is much easier to receive, and then patients, plus you have to use the prednisone with the abiraterone. So there are all these issues that have to be considered. What about the sort of real world or subset evidence? What do you guys think of that? Because there was a report that stated that in patients above 75 years of age did not seem to benefit from abiraterone in the Latitude trial.
Oh, I didn't.
Any thoughts on that?
Yeah, I did see that come out, pretty recently. Yeah, I saw it at ASCO.
Yeah.
So yeah, I have started using a little bit less abiraterone than I used to. It's especially for the older patients.
Right.
Yeah.
And we're seeing more and more of
Did they tease out, was that like because the prostate cancer wasn't controlled well, or was it the cardiac?
No, they had pretty similar, characteristics on either arm. And I wonder if it is the cardiac effect of abiraterone that is overshadowing the benefit of abiraterone. I don't know, but that's one possibility. But again, all these nuances are beginning to come into play, mainly because we don't have head-to-head comparison data, as you said, Phoebe. And, we are committing these patients to a longer-term treatment, so we need to be somewhat selective in what we are committing them to and for how long.
Yeah. I will say it could be it's a bias because of the patients that I see that you all refer to me. Like there seems to be a preponderance of patients that sort of are between or on the borderline between low and high volume distinction. And I will say the combination of the secondary analysis of STAMPEDE, where you saw a benefit of treating the primary up to about 7 or 8 bone metastases on conventional imaging, let alone some of those diagnosed in PET imaging, combined with the PEACE data, which shows very safe and sort of to be determined in terms of long-term outcome, but clearly the best arms or best outcomes so far was those that getting enhanced androgen deprivation plus primary prostate radiation. And so I mean, clearly, my sense is that I'm not seeing the patients from you that have, 42 new METs on the original, bone scan. But it does seem like this is 5, but 2 of the ribs are right next to each other and one's equivocal. And so it does seem like the charted criteria and others are very you articulated as well as possible as I've heard, but it seems like real world has some gray area too in terms of where they are.